Hello, everyone. So finally, you have gathered the courage to listen to the module on screening of disease. I welcome you all to this section. First of all, we are going to talk about the concepts in screening of disease. Since the COVID-19, a lot of new investigations are there, and there is a pressure on the public health system to find out which test is effective, which one is not, which one is giving more false positives, which one is giving false negatives. So I think there's a very commonly used terms these days. So let's get going and let's see what all things are there. In case you are tired right now or you don't feel like studying, I would suggest that this topic is not to be done right now. It should be done when you've already had a cup of coffee or tea and it's early in the morning and you are fresh to understand the concept. So let's just get started and let's learn some of the basic things that you need to know about screening of disease for your exam as well. How many types of screening are there? Screening can be broadly classified into 3 types. We can have something called as a mass screening, or we can also have something called as high mass screening, not MARS. It's a mass screening methodology, or we can have a high risk screening, or we can have a general screening, like it's a multiphasic screening. So primarily, if you want to understand, there are only 2 types of screening. One is mass screening, or we can have a high-risk screening. So this just by force, they've made this category of multiphasic screening. What is a mass screening? Mass screening is MCQ when you're targeting the population as a whole. When you target the whole population, for example, mass screening we do for what? We do for CA breast cancer, we do mass screening. There are guidelines for when to do mammography. We also do mass screening for CA cervix. Right? We also do mass screening for HIV. So all these are mass screening. These are population-based screening methodologies and they are already in place. When will you do high-risk screening? High-risk is for certain group of population. For example, people who are in military forces or in defense, they are being screened regularly because they are at high risk of developing some diseases. People who are in some high-risk occupations, they are also screened regularly for any changes in their lungs or in their mucosa. People who are working in factories, right? So there is high-risk occupation. People who are adolescents, let us say young adults. So they are being screened for any behavioral disorders or mental health changes or things like this. So special age groups can also be high risk. So different high-risk categories are there. What is multiphasic screening? Multiphasic screening is simple understanding that when you are doing the screening in phases, for example, WHO STEPS performer. What is a WHO STEPS performer? We already discussed that in the non-communicable disease chapter. What is a WHO STEPS performer? You take the questionnaire based first. So once all the population is put onto a questionnaire based system, whoever is scrutinized in that questionnaire system, then in the next level, we are going to do some physical examination on those patients. Whoever will be positive on physical examination, on them we are doing some laboratories. So that is one example. Take another example. Let us say I go to the population and in the population, I screen everybody for 3 months of cough, more than 3 months of cough in the last 2 years, or having a chronic cough. And I check them like based on the questionnaire. So there will be people who say, yes, I do have. Some people won't have. People who do have a chronic cough, mind you, I'm not talking of tuberculosis. So let us say people who are having a kind of a chronic cough or cough for more than 3 months every 2 years and things like this. To them, I do their forced expiratory volume in the first second. So once based on the forced expiratory volume, I can classify whether they are having COPD or they are having asthma or they are having any other disease, disease pertaining to the obstructive or restrictive lung disease. So we are going to calculate everything like FEV1, we'll calculate the FVCs, we'll do spirometry. That's what I wanted to say. We'll do spirometry. So you can do whatever you want, right? All these are types of examples of multiphasic screening. No big MCQ till now. But there is another type of screening. We can classify another type of screening. We can have something called as a prescriptive screening, or we can have something called as a presumptive screening. What do you mean by presumptive and what is a prescriptive? Let us say that a patient enters into your OPD with the abnormal vaginal bleed after sexual intercourse, or there is a female who comes and says that there is a lump in the breast or something like this. You write down very fast that go and get yourself screened for cancer cervix, go and get yourself screened for mammography for breast cancer. A person comes with the weakness and malaise and I'm not feeling well and the BP is very high and I've lost weight some time ago, and young adult is there like maybe in 40s, and you think of diabetes mellitus setting in and you say that go and get yourself screened for fasting and plasma blood sugar, postprandial blood sugar. So what is this? You are prescribing an investigation based on the symptomatology of the patient, right? These are technically called as prescriptive investigations. So the prescriptive screening tests are essentially to do what? What is the objective? That now your MCQ start. So what is the objective of doing a prescriptive type of screening? Prescriptive screening is to find out disease early in the course of disease. That is called as early diagnosis. And early diagnosis is essentially what level of prevention? It is a secondary level of prevention. You are trying to prevent the complications by diagnosing the disease early in the course of history of that particular disease, right? I hope I'm clear. What is this presumptive screening? Presumptive is where you presume things. Let us say you do HIV test in all the ANC females. All the ANC females, you do HIV testing. HIV testing in ANC females. Why we do HIV testing in ANC females? You want to find out HIV in the mother? I don't think so. The objective of doing, listen carefully please, the objective of doing HIV test in a pregnant mother is not to find HIV in the mother. Of course, that could be a secondary objective, but the primary objective is what if this mummy was HIV? We have to prevent the HIV transmission from the mother to the baby. So you want to prevent, the objective of your doing HIV screening is pretty clear. You want to prevent the transmission of HIV from the mother to the child, and you want to prevent the disease in the child, and that is why it is called as a primary prevention. So what is a presumptive? You presume that what if she is HIV? So that is, these are levels of primary prevention. The main objective is to prevent the disease in a person, in a particular set of population, by diagnosing the disease in another set of population. But your primary objective is not to treat them. The primary, of course, that is one of the objective, but the main objective is to prevent disease in the child. You do HIV screening for all the blood donated. So HIV screening and blood transfusions. What is that? That's again a primary level of prevention. Why primary level of prevention? Because you are trying to find out HIV in the donor, or you want to save the recipient from HIV. You want to save the recipient. So it's again a typical example of a primary level prevention. If you remember from your chapter in concepts of health and disease, I discussed about the levels of prevention. So these are all primary prevention where you want to prevent the disease. Right? So that's what is a typical MCQ asked again and again. So examples for this you can remember in presumptive. These are presumptive. HIV test in ANC females, HIV test for blood donations. You can also remember another example. Example for this could be like you are testing populations, that is pre-employment testing in high-risk occupations or in any occupation. All these are typically examples of presumptive testing. The prescriptive testing could be anything. The list is endless. How can I tell you what is prescriptive? Example, you do mammography for CA breast. You do pap smear for CA cervix. You do fasting blood sugar for diabetes mellitus. We do oral glucose tolerance test. Oral glucose tolerance test for maybe gestational diabetes mellitus. Now this is an important word, that in gestational diabetes mellitus, the objective of doing oral glucose tolerance test, that is what we do is a 2-hour fasting, 2-hour blood sugar after giving 75 grams of glucose. So the objective of doing GDM is first is to find GDM in the mother, right? So that you want to do prevention of further deterioration of the disease. And second objective is also to save the baby. So there are GDM and OGTT could be basically clubbed in both the situations. You can have a presumptive test and you can have a prescriptive test as well. So all these are typical examples of prescriptive. Another example could be fecal occult blood testing. Fecal occult blood testing, where in for CA colon cancer. So a lot of cancers will have this prescriptive type of screening. So once you have learned what is a prescriptive and presumptive, please remember prescriptives are essentially, basically they are secondary, but of course with certain overlaps, and presumptives are essentially primary. Now we come to the next topic. We are going to talk about timings in screening. What do you mean by timings? You all know there is a risk factor. Let me write it again a little bit more ahead, more up. There is a risk factor. This risk factor is going to enter into the person, or it will start coming up, or it stays in a person, and it is going to give rise to some pathogenesis in a person. Pathogenesis will start. So there is the pathogenesis, and now there is a pretty long time. It's a very, very long time. And then there, after certain years or months or many decades, the person may present with some of the signs and symptoms of the disease. I hope I'm very clear. A person who's presenting with the features of headache and weakness and all these things, if they have diabetes, they did not get diabetes just yesterday. It's not malaria, it's not dengue. They must have got diabetes, like the pathogenesis must have started 10 years back or 20 years back. I hope it's very clear. If a person presents with cervical cancer today, they did not get cancer yesterday, right? If a person presents with dysphagia and vomiting in blood or something like this, and it's not they developed CA cancer or oral cancer just yesterday. They must have developed it a long time back. So the problem with non-communicable disease is that they enter, that is the entry of the risk factors or the pathogenesis phase, very early in stage. I think we discussed this in the non-communicable disease as well, that the time period from the entry of the pathogen or the pathogenesis, onset of the pathogenesis, till the first sign and symptoms of the disease. This is typically longer for non-communicable disease, and it is given a separate name. It is called as a latent period. MCQ number 1, it is called as a latent period. Okay. Can you remember this for me? So what is a latent period? It is the time of the onset of the pathogenesis to the first signs and symptoms. First MCQ. Let's take up another point. Another point for you to understand is that, let us say that there is some point. I don't know where is this point. Just arbitrary. I'm just hanging around with you. Okay. Let's take it some natural point. Let us say that today, if you are diagnosing, let us say that I draw it again. Okay. Let's draw it again. Risk factor is there. There is pathogenesis and there is onset of disease. Let us say this is the timeline. Today, the risk factor has come. Okay. Or very long time, the risk factor has come. And today, the patient had developed some signs and symptoms. Okay. So one is I'm drawing like this, and second is I'm drawing like this. I'm showing you both the things at the same time. So let us say, I don't know where is this point. If you are diagnosing at today, that is the sign and symptom today, this patient is going to die at certain age. Let us say today is 2021. Let us say the patient is going to die by 2050, whatever, 2040. So if in case you have a certain point where you can diagnose it typically early in the stage, very early, right? So probably you can alter the life of that patient. You can alter the natural history. So if this patient was dying in 2040, probably they will die at point number A and they will die at point number B. So they have gained this many years. Are you understanding this? So if you diagnose at point number A, but don't you think, so this is, what is this point? This is the first possible point of diagnosis. This is the first possible point of diagnosis. So you have changed the history. You have altered the death time of that patient. But this is the first possible point. There is another point. You can't ask me where is this point, but there is another point over here that I want to discuss. Don't you think that diagnosing a disease at the first possible point will be very much intrusive into that person? You'll have to enter into my body to find out the to find out probably the first level of pathogenesis. You'll have to go into the pancreatic beta cell to find out what is the level of insulin change, or that is the first possible point of diagnosis. A patient comes to you with CA ovary. They don't come to you and say that I've got CA ovary, doctor. They come and tell you that I've got pain, abdomen, bloating, and abdominal distension and discomfort. So some wise person will do ultrasound and say that you've got a problem. So mind you, we know that CA ovary has a bad prognosis. It's not, why does CA ovary have bad prognosis? It's not that because CA ovary is bad. It is because current understanding, current medical education is that we are not able to diagnose CA ovary typically early. You are diagnosing when the CA ovary is spreading to the adnexa or the pelvic area. That is what is stage 3B or C, when the patient will start getting spread of the CA ovary, right? And that is when the patient are usually presenting. So you are diagnosing not when the CA ovary started, you are diagnosing when the CA ovary presents to us. And that is the problem in non-communicable disease. So let us say you want to catch it early in the phase. That is the first possible point. If you diagnose it at the first possible point, the point for you to remember is that at this point, the intervention will be highly intervention. Whatever investigation will be highly interventional and very much intrusive into the body. It may also be very expensive. Will it be affordable? It may also be not affordable. It is expensive and not acceptable also. By many patients, they won't accept it. So therefore, I agree that there is a very good increase in the mortality, decrease in the mortalities, or there may be a gain in the timeline, but this test will not be acceptable. Now there is another point. If you have understood the first possible point, there is another point. This point is called as the critical point of diagnosis. What do you mean by the critical point of diagnosis? Critical point of diagnosis is any point which can be dependent on any investigation, depending on their usability, feasibility, so many things. There is a critical point of diagnosis where whatever investigation you are bringing in, that is affordable, that is acceptable to the society, and that is doable in the society. So now at this point, if you are diagnosing a disease, so that would be like, let us say this is point X and this is point Y. So let us say you are diagnosing it typically early at point Y, right? So if you're diagnosing it at point Y, probably the patient is going to live till between somewhere A and B. I hope you understand. Let us say this is point C. So I agree with point Y. There may be some loss of the years, but this investigation is useful, and there is, at least you see the positive side, there is some gain in the patient's natural course of history. So this point Y is called as the critical point, which is the ideal point of diagnosis. MCQ start now. If you have understood that, which is the ideal point of diagnosis? The ideal point of diagnosis which you need to remember is not the first possible, it is not the critical point. The ideal point is the first possible point of diagnosis. The ideal point is the first possible point of diagnosis, and critical point of diagnosis is the point where we want all the investigations to happen, because that is affordable, approachable, acceptable by the society, and it gives us a optimum effects and benefits as well. So the critical point of diagnosis, please remember, is the optimum point of diagnosis. It is the optimum point where you get optimum benefit and there is optimum risk. Done till now? Now, come to the MCQs. Now, the time difference, please remember the time difference between the first possible point of diagnosis and the usual point of diagnosis. Do you understand my language? Between the first possible and the usual point. The time difference between the first possible point of diagnosis and the usual point of diagnosis, this time difference is called as the lead time. It is called as the lead time. It is called as lead time. The time difference between the first possible point of diagnosis and the critical point of diagnosis, this is called as the screening time. This is called as the screening time. Are we okay with this? You need to remember this by heart. What is a lead time? What is a screening? Please remember, they both start from the first possible point. Don't get confused. They both start from the first possible point, and many of you will actually get confused in the exam. So I'm cautioning you the mistakes that you guys do. Please remember, they both start from the first possible point. The time difference between the first possible point and the usual point of diagnosis is called as a lead time. Time difference between the first possible and the usual point. Remember, lead for long, L for long, L for lead, L for long, L for lead. Long time is the lead time. The time difference between the first possible point and the critical point of diagnosis, that is the shorter distance. S for short, S for screen. S for short, S for screen. S for short, S for screen. L for long, L for lead. Long time, lead time, short time, screen time, they both start from the first possible point. That is what at the end of the day, the MCQs will matter. Please remember what is a latent time. Latent time. Latent time period is the time between the entry of the pathogen or entry of the agent, we would say, or the onset of pathogenesis or onset of pathogenesis and the usual sign and symptom. That is first. Second, what do you mean by the lead time? Lead time is the time difference or the time between the first possible point of diagnosis, and it is the time difference between the first possible point and the usual point of diagnosis. Third, what is a screening time? The screening time is the shorter distance, right? Screening time is the shorter distance. It is again from the first possible point of diagnosis and the critical point of diagnosis. It is the time gained between the first possible point and the critical point of diagnosis. So, how do you want a screening test to be? What do you want a screening test to be? A good screening test should have short lead time or long lead time. A good screening test will be very useful for diseases which have long lead time, and this screening time should be kind of a shorter. At this point should be lesser. The time difference should be lesser. So there should be a longer lead time. The utility of a good screening tool will be essentially good screening tool will be essentially for which disease? It will be for diseases which have a long lead time. That means they were not being able to diagnose at the earliest possible. They were diagnosed very late, and the screening time should be low. So that's just a small concept for you to remember. Anyways, I know this might be causing confusion that why screening time should be low, but please remember, at least you should remember that a utility of a good screening tool is if the lead time is longer. Now, if you understand this lead time, now there is a problem in lead time. Let us say a question I give to you. A new investigation is launched for cystic fibrosis, which could diagnose the disease, MCQ, 1 year earlier. So that's very nice. You can diagnose cystic fibrosis 1 year earlier than the usual point of diagnosis. That means if point A is this usual point of diagnosis, you are diagnosing this at point B, which is 1 year gain time. So that's very good, very nice. What is the expected outcome? Now the MCQ starts. What is the expected outcome if the investigation was approved by you? You are the authority, right? Assuming there is no change in treatment modality. So now there is an issue that the lead time is there, I agree. But the person who was dying is dying at the same time. There is no change in the time. That's what this means, right? Assuming there is no change in the treatment modality, you're not going to change the course of the history. So what is going to happen? Are you decreasing the prevalence, high survival, high mortality, or no change in the treatment? What do you want to say? That's a funny MCQ, I know. And many of you must be answering it. I know, I'm so proud of you, all those guys who have answered it very nicely. So let's try to solve this MCQ. Let us say I have a clinic. Let us say I have a clinic where we get cystic fibrosis cases every year. We'll not talk of cystic fibrosis. Let us talk of some cancer. Let us talk of CA esophagus. So let us say that there is a certain point. Today is 2021. If you diagnose everybody in 2021, there is 22, there is 23, 24 and 25. So how many years? 1, 2, 3, 4 and 5 and 26. So let me take a 5-year period. 21 till 26, I'm taking a 5-year period. Let us say in my hospital, every year I get 20 cases of adenocarcinoma esophagus. So I get 20 cases, 20 cases, 20 cases, 20 cases, 20 cases and 20 cases. So how many total cases will be there in 5 years? Of course, common sense answer, 100 cases. Every year 20, 20, 20 are coming. Now, I launched this new investigation, which was a new investigation which was made by you. for cystic fibrosis, or in current case, I'm talking of cancer. With due respect to everyone who's got cystic fibrosis, I'm not taking that example because of like reasons. There might be different people who are watching this video module. So let's assume that I take CA esophagus, and let us say that you have made an investigation which can diagnose 1 year early. So let us say you launch it from this year, 2021. So in 2021, if I'm going to launch this investigation, how many patients I'm going to get in 2021? I'll get this 20 plus this 20 who was diagnosed in year 2022, they'll be diagnosed today. So this year I'm getting 20 plus 20. Next year, 2022, these people will come here, these people will come here, and 120 from outside is going to drop inside. Are you understanding this? So in this 5-year lock-in period, earlier I had 100 cases. Now with this new investigation, how many people will I get in 5 years? The period prevalence, it will be 120. So there is an increase in prevalence. So this option is wrong. Done. Now, let us assume that there is no change in treatment modality. That means what? That means, let us say a person was diagnosed at this A point, and if he's like being diagnosed at a B point, which was early, the person is, let us say, is going to die at the same point. Right? There is no change. So now it is very clear. Just look at me now. Now that's the climax of the story. The climax of the story is earlier you had this many cases, and out of them, this many were dying. Just assume. Now you have this many cases, and out of them, the same number is dying, bache. Interesting, right? So earlier you had this many cases, out of them, this many were dying. Now you have this many cases, and out of them, the same number is dying. What is happening to the mortality rates? What's happening to the mortality rates? Earlier, this many are dying out of this many. Now this many are dying out of this many. The mortality rates will decline. The survival rates will increase. Why? Is it happening actually? No, it's not happening actually. This is what is called as, that's what you have learned right now. That is what is called as a lead time bias. So let's talk about the lead time bias. So the lead time bias can be explained by, what is a lead time bias? Lead time bias is it's a virtual or an apparent. It's a apparent or a virtual increase, or we'll talk of the mortality rates. It's a virtual or apparent lowering of mortality rates. In bracket, you can write down with increase in survival rates. That's common sense, right? If the mortalities are decreasing, the survivals will tend to increase. Increase in the survival rates for a disease, for an investigation with long lead time and no change in treatment outcomes or the absolute death rates. So that technically will be called as a lead time bias. It's a bias. Bias means mistake. Mistake is a random error or a systematic error. Bias is, please remember, it's a highly specialized systematic error. It's not a random error. It's a highly specialized systematic error. You must have done, or you will be doing, in the chapter in epidemiology where we talk about the errors. So what is a lead time bias? So in this case, in this MCQ, what do you think you're going to mark? So you diagnose the disease early, but without any change in the death rates. That is what is the lead time. So what do you think? There is higher survival rates. Yes. There is high mortality. No, there is low mortality. There is no change. This is also wrong. So what is the best answer to mark over here? The best answer that you would have marked is higher survival rates. This is the concept of lead time bias. Next is, what are the criteria for a screening test? See, a good screening test. Now, if you have understood all the basic concepts, let us just close this chapter now. What is a good screening test? Good screening test should be affordable. It should be approachable, like people should get it, and it should be in reasonable, and it should be acceptable. It should be approachable. That means it should be available, approachable or available to the general public. It should be affordable, no extra cost, and it should be acceptable to the population. It shouldn't be like you're opening the brain and doing some investigation. And very important, that is what the MCQ will be. The MCQ for a criteria for a screening test, it should be having a reasonable validity or accuracy or precision. What is all this now? Validity, accuracy, precision. It should be valid, accurate, and precise. That is what we are going to learn about now. Let us say let us read what is validity, what is accuracy, and what is precision. See, you must have seen this. Have you seen this sometime in your hostel room? When I was an MBBS graduate, we used to have this dart game, right? In the backside of my door, and before the medicine exam, surgery exam, we all used to play. So whoever used to hit wherever, we used to clap and say that these are the marks we are going to get today. So it all depended on your focusing ability. So people who are very shaky in the morning, that I'm not going to the medicine, I don't want to give the exam because it's a medicine exam today, they'll probably hit somewhere here. Then we say you better not go to the exam. But anyways, what is this game? This is called as a dart game. So I think everybody must have enjoyed this game. So let us say what is validity, accuracy, and precision. Let us say 3 friends like me, we all were playing dart game. So the first person, he comes and hits the board like this, 1, like 2, and like 3. Can you tell me how many times this person is valid? How many times is he valid? Don't you think that he is valid 2 times 1 and 2? This is not counted as validity. So how many times he is valid? The first person. The first person is valid 2 out of 3. Okay. Let us say second person come. You come and play. You come and play, you hit like this. You are a brilliant person. You get full marks, and then you hit here, then you hit here. How many times are you valid? You are valid 3 out of 3 times. That's bingo. How many times are you accurate? How many times are you accurate? Now let's talk of accuracy. Don't you think you are accurate this many number of times? Right? So that means how many times you are accurate? You are accurate only 1 out of 3 times. Okay. Let us say now you give me also a chance. I also come and play. Third person, me coming and playing. I hit the dartboard here, here, and here. Right? So I am poor fellow, simple person, and I hit the dartboard outside 1, 2, and 3. So how many times am I valid? I am 0 times valid. How many times I am accurate? Obviously nonsense question. I'm not at all accurate. How many times I'm precise? Precision means getting the same results again and again and again. So yes, you all were not precise. I am precise. Precision means getting the things again and again. If you just move my head like this, you calibrate me. In technical language, we say calibrate. So if you move my head towards the center, I will start answering a highly valid, accurate, and a precise answer. Because innate, I am precise. Are you understanding? So that is what the MCQs are. What is precision? What do you mean by precision? Precision means repeatability. Precision means reproducibility. Precision means getting the reproducibility. Sorry for my spellings in case they are wrong. Precision means getting the same results again and again and again and again and again. Getting the same results. Mark the word same results. If you're getting the same results again and again, that means you are precise. What do you mean by accuracy? Accuracy means hitting the bullseye. I did not hit the bullseye at all, but this person number 2, you did. So what is accuracy? Accuracy means hitting the bullseye. It means nearness or closeness to the actual value, what you wanted to achieve, actual value or the true value in nature. That is what you want to achieve. What is validity? Validity is pretty simple. You were supposed to hit a dartboard, right? You were supposed to pass your exam. Did you pass or not pass? That is what is validity. Validity means getting the results, desired results within a range. The desired results within a defined range. Within a defined range, which are the desired results. So that is what is validity. So accuracy means hitting the bullseye. Precision means repeatability or reproducibility. Accuracy is nearness or closeness to the true value. Validity is just getting the results within a defined range. Medically talking, let us say you invent a new glucometer or a sphygmomanometer like BP machine. I do jogging and I do yoga, and then I come to you and I say that, doctor, can you please check my BP? You check my BP comes out to be 20 by 0. 20 systolic blood pressure and diastolic is 0. Is this valid? Not at all. This is a nonsense test. So getting a valid range, it should have been at least 130, 140, 150, 160, 110, something within the range which is biologically plausible. That is called as validity. Accuracy is what my real BP is. Are you getting that same BP? That is very difficult to define about the accuracy. Precision means every time you check my BP, it should give you the same results. That may be valid, that may be accurate. So MCQ which came in one of the AIIMS exam a couple of years ago is, digital instruments, they are valid, accurate or precise. Please mark the words, digital instruments, they are always precise. Why? Digital instruments will give you the same results again and again and again. Whatever error was there, that error is going to remain until and unless you calibrate the digital instrument. So digital instruments are highly precise. Validity and accuracy, we have to make them. Right? So these are a couple of things which you need to understand. Based on this, now I think you must have understood why we create such a big media news is there regarding the RAT test in COVID-19, regarding the RT-PCR test in COVID-19. Why is there so much validity, accuracy, precision talks going on? We will discuss this more in detail, but that's all that you need to know in this module about concepts of screening of disease.